Hi everyone, thanks for listening to all my presentations. Today I'll be talking about Zoloft, that is sertraline, and that will be an example of selective serotonin reuptake inhibitors under the broad name known as antidepressants. So, Zoloft, a member of the class Ssri. Sertraline could be sertraline generic, and that would be an example of selective serotonin reuptake inhibitors. Other names could be the brand name like Zoloft and ACT sertraline, AG sertraline, or Apple Zealand. Zoloft belongs to the class of medications known as antidepressant, and specifically or subclass known as selective serotonin reuptake inhibitors. Zoloft could appear in form of concentrate per oral as Zoloft 20 mg per ml or sertraline generic as 20 mg per ml. Could be in form of tablet per oral as Zoloft 25 mg, 50 mg or 100 mg, and it could be generic tablet per oral at 25, 50 or 100 mg. Dosing from 12.5 mg to 25 mg per oral once daily. The maximum daily dose should be between 100 and 200 mg per day, depending on the age of the patient you are now dealing with and of course the pathology. Administration. You can administer Zoloft with or without food. Can administer every morning or every evening, but once daily. Be careful in elderly patients. You have to dilute the oral solution before use, because the concentrate will have a very sharp taste. You don't discontinue any antidepressant, particularly selective serotonin inhibitors like Zoloft cold turkey. No, you have to taper off for over 2 to 4 weeks, particularly if this patient had been on this medication for more than 3 weeks. So you can't stop it cold turkey. This is an advice to the patient taking the medication also. Don't stop that medication cold turkey. Uses. Selective serotonin reuptake inhibitors, using Zoloft as a typical example, will be helpful in the face of major depression, binge eating disorder, body dysmorphic disorder, bulimia, generalized anxiety disorder, obsessive compulsive disorder, OCD. Also useful in the face of panic disorder or post-traumatic stress disorder, premature ejaculation, premenstrual dysmorphic disorder, social anxiety disorder, and menopausal vasomotor symptoms. This is very helpful in the sense that some women will want to avoid the side effects of hormone replacement therapy. So you can grab, selective serotonin reuptake inhibitors for that purpose. When we are trying to switch from one antidepressant to the other and SSRI is involved, then we have to gradually discontinue the first antidepressant or antidepressants, then gradually increase the new one. But if this is involving monoamine oxidase inhibitors and SSRI, then something different will occur here. There must be 14 days between stopping monoamine oxidase inhibitors and starting SSRI, or between stopping SSRI and starting monoamine oxidase inhibitor. So the patient must be on a 2-week break if we are switching from or to monoamine oxidase inhibitor. Adverse reactions: xerostomia, nausea, diarrhea, dizziness, insomnia, hypertension, decreased libido, hypothyroidism, constipation, and ejaculation failure. Other possible adverse reactions are bleeding, anaphylaxis, blood vision, bronchospasm, epistaxis, fever, Stevens-Johnson syndrome, or toxic epidermal necrolysis, and gynecomastia. Drug-drug interaction. We just have to be careful with other antidepressants, alcohol, or street drugs. But even with that suggestion, I'll still leave you, to your discretion and with the cooperation of the pharmacist. And you may seek help from clinical pharmacologists as well. Don't leave out the psychiatrist. In fact, should be the first person to be contacted. When you think you are using a particular drug and you want to place the same patient on SSRI, or the patient is already on SSRI and you want to use another drug, contact now psychiatrist, the pharmacist, clinical pharmacologist, and of course your own discretion. Contraindications. Any hypersensitivity history to this very medication or any selective serotonin inhibitor or to any component of the formulation, then we don't give it. Or if the individual is concurrently using any of these medications, then keep Zoloft or SSR off the table for now. That is linezolid. You can check my channel for linezolid. Monoamine oxidase inhibitor. There must be 14 days gap before you can start SSRI, even if you have stopped monoamine oxidase inhibitors. Pimoxide, disoviran, and methylene blue. Anyone on any of these is not qualified to take SSRI. One is, we just have to be careful when we are prescribing or as patients when we are taking any antidepressant. Right now, I'll deal with SSRI. Okay, SSRI can increase the risk of suicidal ideation. In fact, could lead to frank suicide in pediatric age group or young adults. Therefore, when we have that age group and they are on any of the SSRI, we have to involve the family members. To do what? To look after the patient very, very closely. Keep an eye on any individual that is of pediatric age group and is taking this medication. That is the first thing to do. Be careful because they can end up killing themselves. What are the signs of suicidal behavior that we will be watching out for when anyone is on this medication? Anxiety, impulsivity, agitation, akathisia, panic attacks, insomnia, irritability, mania or hypomania. There may be impairment of platelet aggregation. So we don't use selective serotonin reuptake inhibitors with non-steroidal anti-inflammatory drugs at the same time, because that may then lead to massive bleeding. And we should advise whoever is on SSRI that they should not operate machines. And why that? Because there may be decreased alertness. There is that probability of fragility fracture. There will be pupillary dilatation, which could be leading to narrow angle glaucoma. So in anyone with history of glaucoma, particularly narrow angle glaucoma, we should not use it. Then there's likelihood of prolongation of QT. With that QT, to that point is at the door, and that could lead to ventricular tachycardia, monomorphic, and then degenerate to polymorphic ventricular tachycardia. And from there, if there's no correction, the polymorphic will lead to ventricular fibrillation. If there's no defibrillation, there will be asystole in the next few minutes or hours. And if that is not corrected, the patient may have the end of the journey arrived at, that is death. Life-threatening serotonin syndromes could occur when it is used with other antidepressants. And then can be sexual dysfunction, and we have to be careful in patients with syndrome of inappropriate antidiuretic hormone or hyponatremia. A part of the warning is that it may shift the patient to mania, from depression, or from depression to hypomania. We have to be careful in brain damage or in anyone with alcoholism or anyone with seizure disorder. We have to be very careful when we are using the oral solution in patients with latex sensitivity. SSRI will give more sedation in adults, but it will give more energy in children, so they become restless and become very, very hyperactive. When it comes to selective serotonin reuptake inhibitors, we have the fear that we may be running into serotonin syndrome. But first thing first, let's do our best to prevent this very occurrence. So, don't use selective serotonin reuptake inhibitors, example Zoloft, with serotonergic agents. And someone is asking me, how do you mean serotonergic agent? Don't worry, examples are here. Triptans, tricyclic antidepressant, lithium, phytonin, tramadol, buspirone, St. John's wort, tryptophan. And if monoamine inhibitors, don't give it at this time with SSRI. Why that? Because monoamine inhibitors could impair the metabolism of serotonin. Note, children with attention deficit and hyperactive disorder may develop anxiety, nervousness, insomnia, anorexia, weight loss, and adverse effects on growth. Mechanism of action. SSRI will selectively inhibit presynaptic serotonin reuptake. Okay? And it will have a very weak effect on norepinephrine and dopamine neuronal uptake. So, when SSRI like Zoloft is taken, all what it's doing is there's nothing that's going to affect norepinephrine and dopamine, but it will selectively inhibit serotonin reuptake. Monitoring. We will have to monitor the weight of the patient, and we watch for the suicidal ideation, and we want to know whether this patient is being tilted or shifted to mania, and we look out for the signs and symptoms of serotonin syndrome. Don't worry, I'll be publishing a separate presentation on serotonin syndrome very soon, but you can rewind now and know that there are serotonergic agents that must not be used concomitantly with selective serotonin reuptake inhibitors like Zoloft or sertraline. With that, I've come to the end of this very presentation. Thanks for listening. Remember to share, remember to give thumbs up, remember to pass comment, and remember to subscribe. I appreciate it.